Hello and welcome to the Healthcare Today podcast. Our guest today is Professor Greta Westwood. A registered nurse of over 40 years, Greta has been Chief Executive of the Florence Nightingale Foundation since 2019. A passionate proponent of the incredible work done by nurses and midwives across all sectors, Greta believes that as the NHS looks to expand nurse-led care to reduce waiting times and tackle workforce shortages, nurses and midwives can lead new pathways using new technologies to ensure consistent and timely patient care. Today we're talking about the evolving role of nurses and the leadership needed to support them as they take on expanded clinical responsibilities. A recent Cochrane review suggests that nurses can safely deliver many services traditionally led by doctors with little to no difference in outcomes. From your perspective, what does this body of evidence tell us about how nursing roles are evolving, and what do you see as the most important takeaway for policymakers who are designing the NHS long-term workforce plan?
Thank you. So for those listening to this podcast, those that don't know about Cochrane reviews, it's a systematic review. So in particular, this one was published in February 2026, and it was undertaken by colleagues in Ireland, Oxford and Australia. And what they examined was 82 randomized studies involving 28,000 patients across 20 countries. And they wanted to understand whether nurses can safely deliver elements of hospital care traditionally carried out by doctors. And they looked at all the papers that covered a wide range of specialties. And they also included whether the care was delivered by advanced nurse practitioners or clinical nurse specialists or registered nurses without them being advanced or clinical specialists. And so what the evidence showed is that the nurse-led care is not only safe in many areas, but it actually enhances the quality of care. It also points to the fact that this allows earlier access and more flexible appointments for the patients and improved outcomes in long-term condition management. The thing about this particular review was that it has produced this strong body of evidence that nurse-led hospital care is safe, effective, and often equal or better than doctor-led care across several domains. And importantly, the authors, I think this is the most important thing, the authors say that it's not about replacing doctors, it's about redeploying clinical skills intellectually in order to improve access and patient flow. And as listeners will understand, that is a lot of the problem in the NHS services at the moment. We can't manage to improve the access and also the patient flow. So from my perspective, this is a great opportunity to actually showcase that nurse-led care can genuinely improve care, and it's not simply a substitute for doctors, particularly around long-term condition management, particularly around earlier access to personalised continuity. So nurses rather than doctors can manage that whole pathway from beginning to end by themselves. It's specialist nurse-led pathways, so dermatology and some cancer survivorship, some nurse-led pathways had shown that outcomes were better than doctor-led services. But the bigger picture is it's most powerful when it doesn't replace doctors, but when it redesigns the patient journey. So there's more continuity, personalised support, more time for education. And beyond safety, there was some evidence that increases patients' experience. So I would always advocate for nurse-led services where it's needed and where it provides the greatest impact. Nurses do have extraordinary development programs these days, particularly if they move on to advanced nurse practitioner pathways, and they can do a lot of what previously traditionally was led by doctors. And actually, I did check in the Cochrane review whether they included mine, because I did my PhD in between 2002 and 2010. It didn't include my paper, but ever since the 2000s, I've been an absolute advocate for there are some services that nurses can deal with all by themselves. So thinking about, well, what should be the takeaways for policy makers when they're looking at the long-term workforce plan, which, as you know, is still not published, I think that what needs to be implemented and integrated is the investment in advanced nursing roles as a core solution to the workforce pressures. So it's not a temporary fix, it's actually the thing that will solve help solve the system of patients coming in and coming out of secondary care. So quite rightly, there's evidence in the NHS 10-year plan of committing to advanced practice pipeline, improving the regulation and governance of those that work at the top of their licence, and making sure that another aspect here is making sure that responsibility, I'm sure we'll talk about this in a minute, is at system level accountability, ensuring that the nurse-led models are backed by safe staffing, operational support, and that there's clear organisational ownership. So it doesn't all, when it goes wrong, lie on the nurses' and midwives' shoulders. I guess in short, it validates what I've always thought, which is our professions, if we invest in nursing, we invest in the system capacity, it will improve patient outcomes and we will have a more resilient NHS. And my chat to the NHS policy makers is that the workforce plan must reflect this.
You mentioned about going beyond safety. Now, some studies point to improvements in access and patient experience, such as earlier or more flexible appointments and stronger outcomes in areas like long-term condition management. Where do you see nurse-led care offering the greatest opportunity to genuinely improve care, not just as a substitute for doctors' roles?
I think exactly in that. It's about long-term condition management from in the community, from prevention to support in the community. Avoiding the hospital admissions, really important. That's not just a nurse's role, but an allied health professional's role as well. Working as a multidisciplinary team to enable the patients to live longer, better at home, and it doesn't necessitate a hospital appointment. There are many nurses that work in the emergency department now at advanced nurse practitioner level. And I have to say, it's not very often I go to the emergency department, but I have been in the last couple of months, my husband, and we were only seen by a nurse. Quite remarkable. He came away completely satisfied with the care and the information that we'd been given. So I think where there's a genuine need to make certain that patients are seen by the right health professional at the right time, that totally validates the reason, the necessity for nurse-led care. It's not replacing them, but it actually is complementing that patient's journey. So I hope you've heard that I'm an advocate for it, but there are, I guess the list is shorter than the list of all health conditions. So when a patient's not needed to be seen by a medical practitioner, they can be seen by a nurse. Perfectly wonderful.
Let's move on to the role of technology, especially in ensuring the success of long-term nurse-led care. To you, what does responsible integration of those two big letters AI look like?
Well, I get excited about things like this. I think that AI can genuinely support nurse-led care. We start to understand how it can impact on nursing practice. So what are the patient's needs? What are the system pressures? And I think all of this is essential in trying to design the tools and the setting, the standards for their use. So AI by itself, not to be recommended, but AI that is designed by clinicians with them rather than for them is where this should go, particularly around safety, usability, and the implementation of safe AI. And I think for nurses, all too often, not just in AI, but in digital technology, when it's been implemented in organizations, nurses definitely need to be at the decision-making table because they're the people that have got the clinical judgment. They know how to document care, and decision-making AI systems will be wonderful if they are involved in those decisions. So they know what good looks like. They know when signals need to be implemented and included in the AI. They can test the usability and the workflow, and they can shape the governance. So it will definitely improve the nursing experience, but there's a way to go before our workforce right now are ready to embrace it and use it effectively. I think perhaps when the younger workforce come through, that might be the time where this takes off.
Now, if we see AI as an amplification of nursing judgment rather than an overriding approach to it, when we're talking about AI supporting nurse-led care, who to your mind should be at the table designing those systems and setting those standards?
For the reason I just explained, for the frontline nurses and their leaders and midwives and their leaders, definitely patients and their carers, because if AI changes how care is going to be delivered, patients must have a voice in how it's designed. And they'll bring their own perspectives on the privacy. They're worried about that, the acceptability, the communication, and the trust that they can. So by involving the patient voice, they'll understand that they're trusted in this, and it is a substitute, or it can be a substitute, for the care that would normally be delivered by medical or nursing personnel. So that they definitely need to be part of the co-design. And actually, our health and care systems don't work just with the nursing and midwifery workforce. They work with a multidisciplinary team. So the doctors, the HPs, the pharmacists, the social care also need to be around the table, as AI that supports nurse-led care will ultimately influence that whole team decision making. So it's not just about nurses, it's about the whole team. So about how things are escalated and how the whole team manage the risks. And then, of course, it's the data analysts, the data scientists, AI developers, and certainly the regulators for our professional bodies who need to make certain that they're setting standards that take account of clinical safety, our accountability and responsibility as nurses and other health professionals. And we uphold those standards. And then finally, the system leaders, so NHS England, other parts of the UK, the policymakers, they must create the conditions and the governance frameworks that allow AI to be deployed safely and at scale. So this won't happen overnight. There needs to be investment in the workforce training, evaluation work frameworks, and a clear accountability pathways.
Now, addressing the workforce question, the Royal College of Nursing has stated that we can't deliver the 10-year health plan's ambitions without addressing the workforce crisis. Is expanding nurse-led care an opportunity, or is it an added pressure on an already exhausted workforce?
Right. So it definitely is an opportunity. It represents a significant strategic opportunity for the whole of the health system, but only if it's underpinned by serious action on the workforce sustainability. So we've talked about nurse-led models, and they consistently demonstrate improved access. However, nurses play a central role in delivering the ambitions of the 10-year health plan, particularly around prevention, as I mentioned before, community-based care, reducing the pressure on the acute services. However, the reality is that, as we read in the press, the workforce is operating under extreme strain. So without safe staffing levels, improved retention of the workforce, a pipeline that allows the new entrants to come into our profession and have a good experience, the expansion of nurse-led services risks adding pressure to an already exhausted workforce. So there is a genuine opportunity rather than an additional burden, but I think the policymakers need to take into consideration what does the sustainable workforce plan look like? What investment needs to be included and added into the advanced practice and leadership development of nurses? What is the infrastructure needed to support the nurses, the workforce, to come up with innovations about how to redesign workforce? So they need to be at the table to unlock some of those answers. So yes, it's an opportunity. It would need to be implemented carefully, but it needs to be implemented with the provision and the commitment to invest in the advanced nursing workforce, to make certain that we're not just piling more and more on the nurses' shoulders and expecting them to do this.
Now, you've previously discussed dual regulation for nurse leaders, by that being accountable twice while systemic issues upstream go unaddressed. Now, when things go wrong in nurse-led care, how do we ensure accountability without creating a culture of blame that discourages innovation?
It was in the Health Services Journal. The Florence Nightingale Foundation wrote a letter to the editor about dual regulation. So this has been proposed by NHS England for all non-clinical and clinical managers. And this is particularly important if we consider that the nurse-led models will expand. So what we don't want is nurse leaders. At the moment, they are accountable twice. So we are accountable to our professional regulator, and again, it's through the organisation in which we work. So if there is an underlying cause of failure, where the failure lies upstream, so i.e. the staffing, the workload, or the system design, we don't want to create a culture of blame. Or it's quite often the nurse and the nursing workforce that shoulder the blame when something goes wrong. And what we were proposing in the paper is that we must ensure accountability without fueling a culture of blame by making it proportionate, shared, and system aligned rather than individualized and punitive. We gained these insights because we convened a group of chief nurses in our offices a few months ago, and we asked them, well, what would this mean for you? And quite rightly, they said, we don't want the situation that a nurse can be barred from one organisation and walk into another organisation. So there is some safety built into the regulation. But the chief nurses said that they felt uneasy about the situation, and they really were proposing that we wrote, which I've done, wrote this article and also alerted to NHS England saying, is this really the only possible way that we can do this? So for health professionals, AHPs, doctors, nurses who are already regulated, why would they need to be regulated again? And is this more appropriate? So a better way is that they regulated the non-clinical leaders. And as part of some work that we've done as a consortium, we did develop the NHS Management and Leadership Framework for NHS England. And what's very clear, that's for clinical and non-clinical managers and leaders. If you extrapolate the regulation, and if our regulators totally support the standards set for leadership and management in their scope of practice, then why would we want to be dual regulated? But I'm sure it's easy to work through. It just feels a bit, and that's the purpose of the paper, it feels a bit premature at the moment. Nothing else has happened as a result of the first publicising that there would be regulation for clinical and non-clinical leaders. So we don't know what's going to happen next, but certainly we've had a few comments from our paper, and it's been picked up by this chief exec of the NHS in England. So we'll see.
You've had a remarkable career. Nurse, midwife, genetic counsellor, clinical academic, and now CEO. You've seen innovation from many angles. What's the biggest barrier you've observed to scaling up successful pilot programs across the NHS?
Oh, inertia. So everyone's got amazing ideas about how they can improve their health services. And I kind of always worked with groups of nurses and midwives that want to do things differently, that want to improve the teams or the systems in which they work. So there's not a lack of innovation, but often there's a lack of systems condition which allows the innovations to spread. And take, for instance, a nurse in the Southeast might have identified a new pathway that's improved outcomes for a particular patient group, and it's brilliant. It's picked up in that organisation. It's celebrated in that organisation, but very often it's not picked up by other organisations. So when something works in an organisation for one patient pathway, it should easily be replicated elsewhere. But I think we get stymied into doing pilot studies for short-term projects and not think about the long-term system redesign. And so if I had my time again, I probably wouldn't want to have my time again, but if I was to have my time again, let's create a culture where innovation is part of everything that we do. It's part of the culture in which we work, and that we make that condition a situation where pilots are tested out and then they extrapolated across the country so that other organisations aren't doing the same thing time and time again. The learning is picked up by the original innovator. That would make me very happy.
Finally, you've been a nurse for more than 40 years. You've seen countless reforms and reports. What gives you hope that this time real change is possible?
Well, nobody would argue that the system that the NHS is currently working in is not fit for purpose any longer. And so that gives me hope that the pressures that the NHS is facing are finally being acknowledged as impossible to carry on working in the old way, that we have to develop new ways of working. So the Secretary of State for Health and his 3 shifts, a great idea. Need great innovators to work out how to do that. But I think for the first time in my career, I can see that there's 3 forces that are aligned. Our NHS is using the evidence. So if you take the example of the Cochrane Review, there shouldn't be any reason that nurses with their special interest and with training are able to do the nurse-led care. And I think that's without doubt one of the solutions. And the policy makers are now understanding that the workforce solution is not the whole workforce in healthcare, but it is a nursing solution. So that stuff that we talked about early on, which is when patients find there's long waiting lists, long-term condition management should be able to be prevented, where people are looked after in their home. Patient experience is part of the space in which nurses excel in, and there's growing recognition that the system cannot deliver this. It's hugely ambitious, but they need to be fully enabling the expertise within nursing. And I guess the other thing is the acknowledgement that nurses are leading research, they're designing new pathways, they're shaping policy, and they are taking on these advanced roles, which didn't exist 20 or 30 years ago. But we're not now waiting to be invited. We should already be there. We are already there, but we should continue to be there in shaping the models of care that the NHS needs right now. So I think that's probably why I believe that change is not only possible at this time, it's unavoidable. And it gives me hope that nurses will be front and centre of delivering a new reformed NHS that's not all about hospital care.
Professor Greta Westwood, thank you so much for your time.